beginners. Now, next talk is on the CCC secrets to manage complex cataract by Dr. Gilu George. She is a consultant in cataract department at Giridhara Institute after completing her fellowship in cataract surgery.
Thank you. So, Dr. Kirtana has explained the pearls for a perfect capsular access in a normal routine cataract. Now, I will be dealing with the CCC secrets to manage complex cataracts, specifically in terms of complexity regarding the CCC. So, what makes your CCC complex? When you are in the beginning stage of your surgery, everything will make the CCC complex, right? You have an uncooperative patient with a very sunken eye or problems with bending the instrument, holding the instrument, anything can make your CCC complex. But once you are experienced enough, these are all not a bother. And the availability of a good microscope with red glow and the availability of proper instruments can help in doing your CCC. But what matters most, even for an experienced surgeon, is the patient factors. So patient factors, basically your CCC becomes complex either because of a problem with the visibility of the capsule or a problem with the stability of the capsule. So what are the causes for problem with the visibility? It can be due to a corneal haze where you have problem with visualizing both the capsule as well as your instrument, or it may be because of the density of cataract, vitreous haze, retinal detachment, where you have a problem with seeing the capsule but your instrument can be visualized. Or it could be due to a poorly dilating pupil. So coming to a patient with, in all these cases, irrespective of the cause, the basic principle is that you have to stain the capsule. If you are an experienced surgeon, in a routine case you can do without staining, but in these cases everybody has to stain the capsule and it has to be complete. So when you are doing a patient with corneal haze, here we can see that almost half of your area is hazy, but the rest half is normal. So in such a case, try to start your CCC from a normal area so that you can exactly guide the size of your axis. And once you enter the area of the haze, if possible, do it in a single stretch. If you take out your instrument in between that, then you might find it difficult to continue that because you might find it difficult to see where your axis is. But once you have come out of the area of the haze, then it becomes like a normal case, so you can take out your instrument if needed. And regarding the density of the cataract, in a mature or a hypermature cataract, you already expect that your visibility is limited. But even if it's not a mature cataract, when you have a very thick cortical cataract or a very diffuse PSC, again you will find difficulty in visibility. So if you are in doubt at the beginning of the surgery, just put the red glow and see whether the red glow is proper. In any case where this is not the case, you have to stain the capsule, and the general principles are the same as already explained. Now coming to a poorly dilating pupil. So when you have a poorly dilating pupil, you need to dilate the pupil to visualize the axis. When to use a dilating method and which method to use depends on a case-to-case basis and also depends on the experience of the surgeon with the various methods. Now, in all these cases, again you have to stain the capsule. So this is a patient with uveitis with membranes over the pupil and posterior synechiae resulting in a very poor dilatation. In these cases, the first step is that you have to remove the membranes and release the synechiae, which itself will improve the dilatation to some extent, which may or may not be enough for your surgery. In this case, the dilatation has improved, but it is not enough for your surgery, so you are dilating the pupil with Kuglen hooks. So basically, you are using two hooks to stretch the pupil in opposite directions, and you can do it in multiple areas to get a irregular but dilated pupil, and you can do the axis properly. Now the problem with stretching the pupil is that you do it at the beginning of the surgery. There is no guarantee that the pupil will stay like that till the end of the surgery. So in cases where you expect that, it may not be the case, especially in cases where you expect, like in IFIS, you should never go for stretching of a pupil. You should choose a device which will stay in the eye and keep the pupil dilated until you require. So you have various methods for that. Basically, you have the hooks and the rings. So just a basic overview. In all these cases, one point you have to remember is that when you are staining the capsule, you have to go under the pupil and stain it. Because otherwise, once you dilate the pupil, the area where you are going to do the axis will not have stain. Now, when you are using hooks, you can use 4 or 5 hooks, and you have to remember that the shape of the pupil will depend upon the number of the hooks that you use. So in this case, because you are using 4 hooks, you are going to get a square shaped pupil, and you are doing a circular CCC in a square shaped pupil. So the size, shape and the position of your CCC you should have in your mind. Like in a normal case, you cannot depend on the pupil size or shape to guide your axis. So if possible, you can use a axis marker. Otherwise, you should have it in your mind how to do the axis. Whereas when you do a B-hex ring, you get a slightly more regular pupil, but still it's not a circular pupil. Now, whichever method you use, at the end of the surgery, you are going to get a slightly dilated, irregular pupil which is not reacting to light as in a preoperative pupil. So, do you need to dilate the pupil in all the cases? For example, in this case, the dilatation is not very poor, but it's not enough. So, when you are a beginning surgeon, in this case, you have to dilate the pupil. But once you are experienced enough, you have another option where you go slightly under the pupil. Basically, you are not seeing the edge of the axis, but you know where it is. Okay. So, in this condition, you have to refill the AC multiple times with viscoelastic because you need to get whatever dilatation you can get. And like Dr. Ketana explained, when you reach the side port area, you have to change the direction of your instrument. Now here you are not seeing the axis, but you have to change it. That is why I said this should not be done by a beginning surgeon. It should only be done by someone who is really familiar with a normal CCC. The advantage in this case is that at the end of the surgery, you are going to get a regular round pupil which reacts normally. So that was about the problems with the visibility of the capsule. Now coming to the problems with the stability of the capsule, the stability can be affected because of either because the zonules are weak or the zonules might be intact, but it's because of the type of the cataract. So far we have been discussing about doing CCC with a cystitome. Now, why are you able to do it with a cystitome even when it is not holding the capsule? Because you have a support that is given by the underlying nucleus. But when you have a problem with the stability, this support may not be there. So there you will require instruments which will hold the capsule and help you doing the CCC. So the most commonly used instrument will be the Uttrata forceps, which is used through the main port. Because you are using it through the main port, if you are not holding your instrument properly, the OVD will come out and your chamber will be shallow. So in such conditions, what you can use is a microcapsular axis forceps, which can be used through the side port. Now because it is used through the side port, the chamber will be much more stable. But what you have to keep in mind is that when you are using this instrument through the side port, at the area of the side port, if you release the capsule, you will find it difficult to regrasp it. So either do it in a single stretch near the side port area, or when you reach the side port area, you will need to go to the main port to complete the capsule. Now coming to zonular weakness. In many cases, preoperatively you might have diagnosed zonular weakness, either because of your slit lamp finding, or you might have looked very carefully because there is a history of trauma or there is pseudo exfoliation or something like that. But in many cases, you will miss the weakness preoperatively. Now, when you miss a case like that, very often the first clue regarding zonular weakness is this. You can see that when you are trying to start the axis, the capsule is getting wrinkled. So you find it difficult to continue it with the cystitome, you are switching to a microcapsular axis forceps. So again, as I said, when you reach the side port area, you might have to go to the main port to complete the rhexis. The rhexis has been completed, but it's really small. So because there is zonular weakness, you are going to use capsule hooks. And with the help of the capsule hook, the surgery was completed, CTR put, IOL put, and the hooks removed. Now because the rhexis is very small, at the end of the surgery, you are enlarging the rhexis so that it becomes ideal size. Now, do you need to use these instruments in all cases of zonular weakness, or can you complete it with the cystitome? So this is a patient. This is a case of pseudo exfoliation with poor dilatation and zonulodialysis. So because it's a poorly dilating case, you have to dilate the pupil first. And since you are planning to use capsule hook, you are going for a stretching the pupil. You are not using iris hooks. Now, after dilating the pupil, basically what you can see is that you are starting the CCC with a cystitome. Once you get a little bit of the rhexis, you put a capsule hook at that point. So that part of the capsule becomes stable. And as you proceed with your excess, you keep on inserting capsule hooks so that you are completing the CCC with the cystitome but with the help of capsule hooks. So this was about a patient with zonular weakness. Now in patients without zonular weakness also, because of the type of the cataract, you can have difficulty in CCC. Mostly this is seen in intumescent cataract where your cortical fibers are so swollen and you are not getting the support, or it might be a Morgagnian cataract where you have a very small nucleus which is rotating in the back, which is again not giving support, or you have like a fibrotic or a fragile capsule. Now these type of cataracts, they have their own set of considerations and complications which will be dealt in detail by Dr. Tindu. So over to Dr. Tindu. Thank you.
Thank you, Dr. Gilu, for giving us a wonderful insight.